Okay, Nadine, I think we're ready to go.
Oh, fantastic. Thank you so much, Bobby. And thank you to all of our CVAC committee members for joining us again today for our 14th Community Vaccine Advisory Committee meeting. Welcome. I want to get started. I'm just thinking as a reflection of how far we have come in this process and all the work that we've been able to accomplish together over the past number of months. When I think between our first meeting at the end of November until now, to think that California has administered more than 33 million doses of vaccine is just mind-blowing. To think that we've done that in just such a short time. So I'd like to call the meeting to order and welcome all of you, and we'll go ahead and get started with our meeting processes, and then I'll jump in with some opening comments from from myself and also our co-chair, Dr. Erica Pan, state epidemiologist. But Bobby, can you start us off with our usual ground rules?
Sure. I was thinking by this time I should ask one of the members to do the ground rules because you all know it so well. But just as a review for all of our members and for members of the public, we'd like everyone to do their best to keep their cameras on. Our meetings are very interactive, and if you can keep your mics on mute until you are ready to speak. I think everyone now knows how to use the hand raise icon, so don't hesitate to click that little icon when you're ready to make comments or ask questions when we get to each part of the agenda. We welcome, as always, our two wonderful ASL interpreters, Katie Sales and Vicki Kennedy, and we also have closed captioning for our members. The public is listening in via telephone lines, both in English and Spanish, and also on our YouTube live stream channel, Community Vaccine Advisory Committee. So if you have any technical difficulties during the meeting, please don't hesitate to put that in the chat and we'll do our best to help you rectify those. Thank you, everyone. Nadine and Erica, would you like me to go through the summary of the public comments now or after your opening comments?
Yeah, please go ahead. Thanks, Bobby.
Okay, great. Well, you can tell that we have opened up the vaccine allocation process because we had only 26 comments from individuals and organizations in our public comment. And I'd just like to summarize those quickly for you. I know you've all had a chance to read the actual comments that were sent in by members of the public. The National Black Church Initiative has organized hundreds of volunteers throughout the country, and they have provided information in public comment about how they can help staff vaccination clinics. An individual with disabilities and her chiropractor wrote in stating that they were not able to get vaccine due to mobility and accessibility issues. 5 individuals wrote in to urge the California Department of Corrections and Rehabilitation to reduce incarceration in state prisons and to prioritize vaccinations for both staff and inmates in those prisons. One individual wrote in with a concern about the drastic drop in school-age vaccinations during the pandemic. 8 individuals, several from the Community Vaccine Advisory Committee from Ventura County, a group of Ventura County stakeholders, wrote in about their concern about farm workers getting vaccinated due to a lack of supply of vaccination in Ventura County and wondering how Ventura County could get access and allocated more vaccines. One individual wrote in that there seemed to be no equity benchmark in the governor's vaccination plan. One individual wrote in about confusion about being given a Pfizer COVID-19 vaccination second appointment 4 weeks after their first appointment instead of 3 weeks. And one individual wrote in opposing vaccine passports. And that is the summary of the public comment that we received since our last meeting.
Thank you so much, Bobby. We have come a long way if it's 26 as opposed to 26 pages. So thank you so much. As always, I like to begin these meetings with a grounding of what brings us into these meetings, and the approach and the values that the state of California and we all as a body have taken in thinking about and making recommendations about California's vaccine strategy. And I want to lift up and highlight that when we started this process and we talked about grounding in the principles of safety, equity, and transparency, they were extremely apt and timely, because over the last many months, we have wrestled with all of those issues. And you all have profoundly informed California's approach to our vaccination strategy. And I want to express my gratitude and on behalf of the administration, and to really reflect on all the work that we have accomplished over the past many months. Our next meeting, in looking at where we are with our vaccination now that vaccination is widely available to all Californians, and for the person in Ventura County, we will follow up with our team at CDPH to make sure there are no concerns there, because there should be ample supply throughout the state. As we are looking at all that we've accomplished and recognizing where we are right now in our vaccination effort, I want to make the announcement that our next meeting, our meeting in June, will be our last meeting. We are very, very grateful for the time, the commitment, and the effort that you all have contributed to this effort. And we certainly want to be very sensitive and thoughtful to your time in not continuing these meetings indefinitely. At the same time, if there are any urgent issues, we will certainly feel free to reach out and seek your counsel. But for today, we wanted to start off the meeting by letting you know that this will be our second to last meeting, and then our June meeting will be our last. And as we are heading into this meeting, you know, at our last meeting, we talked a bit about we made time and we reserved time for the information about Johnson & Johnson and what was happening at that time. And again, we have some timely information for you and conversation with you for you about the Johnson & Johnson resumption and how that's been going, and in, you know, also further developments in terms of the FDA approval, the FDA emergency use authorization of the Pfizer vaccine for children 12 to 15 years old. So we'll get an update from that from Dr. Erica Pan. We will have an update on our equity goals. And Denny, where are you? I don't see you on the camera, but Emily Estes is here to talk about race and age. So thank you for continuing to lift that up. And we've been working very hard to be responsive to you all and all the issues and concerns that you all are sharing. So we'll talk about how we're meeting our equity goals, as well as promised, we will have a conversation about vaccines for individuals who are unhoused or living in public housing, SROs, or supportive housing, some of the best practices and lesson learned. And finally, we'll share a greater update on our outreach and community engagement. That was another thing that we didn't have as much time for at our last meeting, and that we heard was something that folks wanted to hear more about. And so we will hear more from our amazing team on that. And with that, I will pass the mic to Dr. Erica Pond, my co-chair and our state epidemiologist.
Great, thank you so much, Nadine, and good afternoon, everyone. Welcome. I want to sort of echo a few things that Nadine mentioned as well. I think, it's been really just a wonderful part of the growing opportunity of this pandemic and working with all of you on this committee. I think we've shared a lot of milestones together and progress and transitions. And again, we've had a lot of, I think often a lot of very timely updates that happen at the same time as this meeting. And, really want to give thanks to all of you and a huge credit and gratefulness for all of your input. I think the improved relationships and collaboration that we've developed from this committee and the sort of offshoots that have developed have really been, invaluable to the state and to our administration and to our pandemic response. And I'm really grateful as well that I think many of these relationships and collaborations will continue well beyond, our last meeting next June. A couple other announcements. I just want to make sure I also acknowledge, as a Chinese American woman, that it is Asian American and Pacific Islander American Heritage Month. Especially important during this time where there's so much anti-Asian hate crime, and really thinking about this in solidarity with other groups who are experiencing similar harassment, violence, and hate crimes, and hope we can all continue to publicly denounce racism and xenophobia of all communities that experience this, and that we can continue to build together inclusive and equitable communities. A couple other sort of more vaccine-focused announcements I wanted to mention, acknowledging there have been a lot of great announcements coming out of the federal administration. One addresses transportation, which has been a big topic of interest for all of us and all of you on this committee as well. So there's a new partnership with Lyft and Uber that has been sort of announced at the federal level, and both of those organizations have apparently had a way for people to donate rides anyway for getting to vaccines. And I think there's a new federal partnership. So we're working to find out more as well. This is a brand new announcement. We'll share any details we have as soon as possible. It looks like on their sort of public websites that they are activating this new partnership in the next coming weeks. So we will have more to come. But I think, again, there are ways on their apps and websites now to get donated rides to get vaccines. And then another hot topic, just to kind of mention, and we'll send a link, in the chat and or later at the end of this, as far as vaccine verification, if people are losing their, little card that they get or things like that, there is a way to request a printout or follow-up documentation from us. It's not as user-friendly as we would like. So we're working on that, but there are ways to do this right now. There's a couple different ways. And again, we're working hard to kind of streamline that, make it more user-friendly, make sure there are different languages. So stay tuned on that. We'll spend more time on that in June. So with that, maybe I'll go to the next slide. So, sort of with this theme of progress and transitions, I'm going to kind of give you a little bit of an overview. Really proud to say we've got some of the best trends in the nation right now with our cases and hospitalizations, incredible overall progress in vaccine delivery and coverage. So we'll review some of that. And then as mentioned, we'll really cover all the work we still have ahead of us as well to focus in on disparities that we are still seeing and how we're working on the ground game with local partners to provide resources and close those gaps. But I think a lot of our great trends are certainly a huge testament to the vaccines working and our community and our state working together to use all of our tools to fight this pandemic. But that light is getting brighter and brighter at the end of the tunnel, but we're not at the end yet, and we're still seeing some outbreaks. So we'll continue to see transmission until we can get more and more Californians vaccinated, and actually more and more people around the world vaccinated. So I think that's important to keep in mind, especially as we're seeing a lot of surges around the world and the heartbreaking situation in India. Really grateful as well that both our state and our nation have contributed to that cause. And then I think the other just high level thing I wanted to mention in opening is that, clearly we are seeing a shifting point and transition as far as, for so long, we and this group have been thinking about and talking about when the demand, outreached the supply, and we're definitely shifting now. We have plenty of supply, and now we need to kind of increase demand. And the strategies early on were really centralizing a limited supply to a smaller number of locations with high throughput, high volume. But now we really are shifting that strategy to bring the supply to people, meet people where they are, answer people's questions where they are in ways that seem appropriate and with trusted people. So again, instead of drawing people in, we really need to bring vaccine to people. So a lot of huge efforts on that. And a lot of that you'll hear about later in our meeting today and moving forward with those strategies. So with that, I'll start to talk about the epidemiology. Next slide, please. This is just a snapshot of on our main page. You can see kind of where we are with cases. I think this case rate is something that to keep an eye on, and really the lowest we've seen probably ever since over a year ago, but 3.6 new cases per 100,000 per day, one of the lowest in the nation for sure, especially for a large state like ours. And our deaths continue to decrease, and overall average are absolutely decreasing, and we're actually at the level similar to a bad flu season actually right now. So that is actually very encouraging as well. Our test positivity has also been wavering around 1.1%, really the lowest we've ever seen, and again, one of the lowest in the nation. And our milestone of 33 million vaccine doses administered has already been mentioned, but that's there. Next slide. And then this is, you see this, I think every time when I come give this overview, but just again to show you the summer peak and then the winter surge. And then these orange lines on the right-hand side of this graph are showing us the 1X is 10% vaccine coverage of fully vaccinated eligible Californians. The 2X's is 20%, and then 3X's is 30%. You can see as we've, moved forward, we continue to see very flat and stable and decreasing case numbers. Next slide. And this is sort of another way to look at the blue line here is similar to the one I just showed you with cases. And then the red is actually our deaths. And you can see again, those peaked with a little bit of a time lag after the surge of cases, but again, decreasing and really low and lowest we've seen. Same with hospitalizations and ICU admissions, all are at really the lowest we've seen. And new admissions is not on here, but also lower than we've seen last fall for sure. And back to levels really before the summer surge. Next slide. This is just our hospitalization forecast that they continue to decrease. I think, it will looking very stable to decreasing over time. Next slide. And then also of interest, and this we're updating every 2 to 4 weeks on our website. This is actually breaking news now. We'll get this posted tomorrow or Friday. But our latest seroprevalence data, and we look at these at a 4-week average for the state, we are actually at 67% in California, which is, a huge accomplishment. This is really a mix. We can't distinguish from this how much of this is vaccination versus prior infection. But what it does show is, basically antibodies and the percent of people in California that have antibodies. And this is a mix of the reported antibody testing that gets reported to us based on any clinician testing that is mandated to be reported, and actually blood bank data. So not all people there's a much higher pre-test probability of people are being tested to find out, but I think also just blood bank data and multiple sites across the state. So, and you can see there's a variation. Our rural Northern California has the lowest seroprevalence, around 49%, but at our lowest southern border, we're up to 76%. So again, this is a combination of vaccination, but we've seen a lot of progress in these numbers with vaccinations improving over the last several weeks. Next slide. And then this is where we look at this based on our Healthy Places Index quartile. So as you've been getting familiar with the way we think about our communities in California, so our least healthy communities are quartile 1 and have had throughout the pandemic the highest proportion of antibodies against SARS-CoV-2, because as we've mentioned before as well, there's been a disproportionate impact of infection in these communities. But you can also see the gap is closing a little bit there, and you can see sort of the increase in antibody prevalence over time. As of May 1st, we saw that more than half of people living in the lowest Healthy Places Index quartile have detectable antibodies. Next slide. And then, of course, another topic of interest, wanted to just give you an update on where we are with variants in California. So we've been sequencing in March over 13% or so of all the specimens in California have been sequenced, and there's definitely a significant time delay, and we're working on improving that time delay, but improving that proportion in April. But as of April, at the end of April, this is the trends we're seeing. So the orange and gray lines here are the Western coast, or also known as the California variant, which was really dominating in our state up through February. And then you can see here that that's been decreasing. And actually what's been increasing is the UK variant, or the B117 variant. So almost half of our isolates right now are actually B117, but as I've shown you from our other data, thankfully, even though that is on the rise, we are actually seeing stable to decreasing cases. So all of the other efforts, again, are really helping us in California, the vaccination, continuing to practice all of our other public health protections. And then also starting to increase just a little bit, still under 10%, but on the increase is the P1, which is the Brazilian variant. So we're keeping a close eye on that. And we do have a few isolates of the Indian variant as well, the B1617. It's not on this graph because it's less than 100 isolates, but we are seeing that and monitoring that closely as well. Next slide. And then back to our vaccination progress. So really, again, excited to say we're getting close to almost 20 million people with at least one dose administered, and that is 62% of our population age 16 and older. And then you can see as well that we have 46% of people are fully vaccinated. And then we'll talk soon about how our denominator on that is going to change. But again, really exciting progress here in California. Next slide. This also just shows you kind of how much we vaccinate per day and the trends that we've seen. So we had a peak where we had kind of a highest match of a lot of supply and high demand. And then as we were opening up to all eligible, you can see we've had some decreases over the last several weeks. And there's also some time lag here in reporting. But again, over 33 million doses administered. And I think really encouraging, I think on our next slide, it'll be in another one, but we have a pretty steady over 250,000 or so vaccinations per day. So while there's been a decrease, it has still been a large number per day that has been encouraging. And then the other thing we wanted to share, this has been intermittently as we continue to do matching, we've been sharing this information with the public, but we have been doing periodic matching where we look at our entire immunization registry. So everyone that's been vaccinated between January 1st, this particular time period, goes through May 5th, and then also all the reported cases or all the reported people that have tested positive for COVID-19 in our database. So we looked, and with this time period, January 1st to May 5th, over 13.5 million fully vaccinated individuals. Of those, there were around, as you can see here, 3,620 post-vaccination cases, or people that tested positive. That percentage, though, is 0.027%, an extremely low proportion of the people who have vaccinated who have tested positive. Many of those who we've heard about in specific settings have been part of screening testing or other things where they had no symptoms. So very often what we're seeing is really no symptoms or mild symptoms in those people. And then among the 36, 24% of those were hospitalized, 1% were in deaths. And with those, we haven't had a chance yet to even see if those were incidental testing or if the COVID-19 was really the cause of hospitalization or death. So more information, will continue to evolve in that as well. And this is pretty similar proportions to what the CDC and others are reporting. Next slide. So again, what we're receiving is about 2 million doses per week. It has remained relatively flat recently, but again, we have plenty of supply related to demand. And as nation supply increases, we could see more, but right now we are definitely meeting the demand. And then I was starting to mention this earlier, but again, we're seeing about more than 260,000 doses administered per day, and it's been pretty steady over 250 or so for the last several days and the last couple of weeks. So that is encouraging as well. Next slide. And then, I think when we last met, we had just actually gotten news of the pause with the Johnson & Johnson vaccine, so wanted to give some updates on that. So on April 23rd, the FDA lifted its pause on the use of Johnson & Johnson, and there was a review by a federal vaccine safety review panel. We also had our Western States Scientific Safety Review Group also meet and review the data that the ACIP reviewed as well. And all agreed that the vaccine's benefits far outweighed the risks, and the vaccine is safe and effective and recommended resuming use for all eligible Californians. And I think what was really important to us in this setting for California was also to make sure that there's appropriate educational materials to inform and make sure that people all have informed consent around the very rare and low risk of these clots with low platelets and other available vaccine options, especially for women under the age of 50 as the one that did have a higher risk than others in the general population. Next slide. And then the really exciting breaking news, and even since we created this slide, I have just heard the update about the ACIP, but you may all likely know that on Monday, the FDA approved the amendment to Pfizer's emergency use authorization to expand use of the vaccine to 12 and up. So before it was 16 and up, and now it's 12 and up. And there was data from these phase 3 trials that there's good efficacy and vaccine tolerance. There are around 2,200 individuals in those trials, I believe, and I just heard the late breaking news that ACIP met just now, and they all voted to recommend use of Pfizer in 12 to 15-year-olds. Next slide. So here in California, we have been planning for this, and we've been partnering with California Medical Association, the American Academy of Pediatrics, the California Association of Family Practitioners, and Blue Shield as our third-party administrator to expand availability to more youth-serving clinics. So really making sure that we can streamline enrollment, make it easier, so long as we can still make sure we're tracking vaccines. I think this is also really important, again, as I mentioned earlier, this transition of shifting from pulling people into mass vaccination clinics and getting vaccine out into the community and making sure we can have vaccine in places where people can talk to their regular providers, talk to their trust providers, get their questions answered. And for kids, actually, specifically, it's really important that we get our kids caught up on vaccines too. I think over the course of this pandemic, there's been a large impact on everybody. I think obviously the other great thing about this approval is this will allow our teens to, feel protected and get back into more of their activities and really back to the social activities that they've been really craving, and to get caught up again on their vaccines. We want to make sure we don't start to see some other vaccine preventable diseases show up while we do our jobs preventing COVID-19. And then you'll hear later about more of our communication planning for empowering youth to advocate for their vaccinations and really hopefully help get the whole family engaged if the whole family is not vaccinated. And then the other thing around this that we will hopefully get posted later today or tomorrow at the latest is we have a template minor consent guidance draft. So that is, still up to the individual providers on how they are going to implement this. But we'll have a template consent form, and parent or guardians do need to consent for minors 12 and up unless they are emancipated minors. But the parent or guardian can have a written consent and send it with the child. The parent is not with them. And then there are some clinics that are doing other more creative things that they do with other healthcare for teens as well, like having a phone call or sometimes a video sort of consent available. So those are other things that are possible, and we'll have some templates and guidance available very, very soon. It's just in our final approval processes. Next slide. And as far as boosters, this is another common question we're getting. So we can't say too much yet. We do know that there's at least 6 months of protection in the current vaccines and the data we're seeing, but these vaccines have only been around for about 7 months. So a lot of study and research happening, both with the research community and the manufacturers. So we are, scientists are working hard on this question about whether or not we will need boosters for COVID-19 vaccine and any timing, but we don't have any information to share at this point, but continue to stay tuned and we'll be tracking this closely as well. And next slide. So I think, and in closing, this is just really a segue actually to, the next topic will be thinking and looking at our vaccine equity data and where we've been. This is looking at our at least one dose numbers and proportions. And you can see, we had a huge gap in the beginning, I think in March when we started to allocate disproportionately so that we had at least 40% of our doses allocated into our Healthy Places Index Quartile 1. We started to close that gap. As availability and eligibility opened up more, the gap widened again, unfortunately, but we are making progress, as you can see here again, with a lot of the recent efforts, really, again, working on that ground game to increase the proportions again of people in quartile 1 and quartile 2 to increase that proportion getting those first doses in. So we're really pleased that we're making that progress, and you'll get a deeper dive on that in a demo with our epidemiologist after this. I think that is my last slide.
So we'll take the slides down so we can have some Q&A with Erica. And Charles, why don't we hear from you first, and then Ronnie, and let's make sure you introduce yourself so that members of the Community Advisory Committee know who's speaking, and also members of the public. And then Denny, maybe we'll go to you and Diana.
Good afternoon, Charles Bakke with the California Association of Health Plans. Just want to thank the good doctors for all of your hard work. It's amazing how far we've come in just a few months. It's really incredible. I know everyone on the committee thanks you for your diligence and your team and the hard work that you and your partners have put into making this successful. So good job. I was curious as a parent and as a Californian, what's the, and I apologize if this has been covered in the media, what's the total population of 12 to 15-year-olds in California? That's part A of the question. And part 2 of the question is, how many doses of Pfizer are we receiving a week or a month? And I asked the question just as a level setting, as what's the realistic expectation for really deep levels of vaccination prior to the fall?
Yeah, great question. So I think this particular age group is only about 2.1 million individuals, 12 to 15 years of age. So we typically, again, are vaccinating over 250,000 people a day. So, we have capacity. We have capacity to do at least double that in a week. But so supply-wise and capacity-wise, I mean, we theoretically, if every 12 to 15-year-old came in, I think it's going to be a little bit of a, again, clinic appointments and availability. But we have. I don't know the exact numbers of Pfizer, and we can get that back to you, but I think we anticipate that, it's another next level, which is great. And I think I'm also a parent of teens and super excited. I actually have 2 in this age category, so excited to sign them up as soon as I can. But it is, I do think, and then actually what I didn't say is that we are hearing more and more that probably for the 5 to 11-year-olds, there may be data as early as September. There may be application by September. So I think we are definitely going to get our teens vaccinated by fall, certainly all that want it, and we'll hope to convince as many of them as possible. And then even our younger children, there may be some data and some authorization by this fall.
Great. Thank you, Charles. Maybe we should have everyone who has 12 to 15-year-olds raise their hand if they're excited about the summer coming. Let's go to Ronnie. Don't forget to introduce yourself, Ronnie.
Thanks, Bobby. Ronnie Kelly, San Bernardino County Department of Behavioral Health Director and representing the County Behavioral Health Directors Association. So I want to say off the bat, thank you so much for the state's focus, the administration's focus on behavioral health. This is Mental Health Month. It's really important. But bringing behavioral health and equity in line with the 12 to 15-year-olds, I'm wondering, have we thought about a process for wards of the court, so our foster youth who are very high risk, to be able to be vaccinated? Because the way we do it now is we get a court order, we get the court to approve. So is there a process maybe where, since Superior Court is a state agency, that we could have one a united message to them so it's easier for our youth who are in the system to get the vaccine?
Great question.
That is a great question. I will acknowledge 2 things. I know we are working on it, but I don't know the operational implementation of that. So I don't have, but we can definitely get back to you on that. But I know it's been a high priority and something that we are looking at. So we can definitely follow up and send some email follow-ups on that.
Great. Thank you, Ronnie. We'll definitely make sure to follow up on that. Diana, I know you had a question in the chat. You want to ask it, and then we'll go to Denny's question in the chat, and then we'll see how much time we have for a couple of more questions.
Sure. Thank you all so much. I'm Diana Telebsen Torres with the UFW Foundation. You know, our outreach and education staff on the ground, we were just telling me earlier today that the J&J concerns continue to really surface when we're talking to individuals who haven't been vaccinated yet. So I'm wondering what the data looks like as far as how many J&J doses have been administered since the pause was lifted. And how does that compare to maybe like the prior week? Just because initially we were seeing a lot of excitement from many farm workers and farm worker community members about the J&J because it was just a one dose. So we're just wondering we're trying to look for strategies here and brainstorming to figure out how do we address this issue and the type of communication that's necessary so that we can say, hey, after the pause, this is how many people got the vaccine and they're all doing okay. So we're really trying to think through, especially in the rural regions where we thought J&J would be great because it could be administered just once.
Yeah, that is another great question. And I don't have the data at my fingertips. I do know anecdotally when we've been just having conversations about it, there was less of a drop than we anticipated. So it certainly may be in specific communities, I think, where it's been more of an issue or less. But we're happy to get you that data just to help with that messaging. And, we continue to think about some of the messaging as well. And I'm sure our communications team would love any thought and feedback on that as well.
Great, thanks, Deanna. Jenny, why don't we go to you for one question, and then I think we'll have to move on, but Aaron and Deborah, we'll come back if we have more time, or please put your question in the chat. Denny, introduce yourself.
Great, Denny Chan from Justice and Aging. Thank you, Bobby. I was going to reserve my spoken time for the next section because that's what I've been waiting for so long now, but appreciate the opportunity to ask the question. I was just wondering, there's been a lot of reporting in the news about people not showing up for the second dose, specifically of Pfizer, Moderna, and I'm wondering if we're seeing that trend play out here in California and how you all are thinking about that, if it is indeed showing up. Thank you.
Yeah, thanks for the question. It is showing up a bit, and so we have started to add that to some of our messaging and trying to really emphasize the importance of that second dose. I think, again, I think as far as that booster, it really helps your not only your antibody response, but your T cell immunity. It's also going to help people more for variants. So wanting to emphasize that along with the idea that vaccine is actually more protective and a stronger immune response than prior infection. I forget the actual numbers on this as well. I have one in my head, but because I'm not 100% sure, I don't want to say it if I'm not right. But we are seeing some of those trends. I think not as high as the national number, but we are seeing some drop off in that as well. And we do see that with other, 2 or 3 dose series in prior vaccines as well, and want to continue to encourage people. So again, that's another great area. We'd love any other feedback on as far as what might be helpful for those of you on the ground trying to get people back in as well.
Thank you, Denny. I think, Nadine, we're ready to move on to our equity discussion.
Thank you. And thank you so much, Dr. Pond, for that update. So when it comes to equity, as you've heard us talk about this before, and for earlier in the year when we pulled together some smaller work groups to work through and identify what some of the challenges and strategies that we might take to address those challenges. I think many of you have heard me say that when it comes to equity, that this is hard, right? This is not something that we just accomplish overnight, that this is something that takes a lot of sustained commitment. And there are a few of you who will remember when I said, okay. And so when we know that this is really challenging, we know that it takes longer, and we need your partnership and your patience as we're moving this forward to really try and continue to pursue equity. And so as you all know, the state has taken a 5-pronged strategy to equity, including allocation, network, outreach, communications, using trusted messengers, and then using that data to course correct and see how we're doing and continue to follow and adjust our efforts accordingly. And so the last slide that you saw from Dr. Pan was some of that data, which shows us how we are doing in vaccinating our most vulnerable communities in California compared to our most advantaged communities. And as we saw in that slide, there was a while there in at the end of March, beginning of April, where things were coming together and it looked really good. And then as eligibility opened up, we saw that divergence again, which is something that we heard from you that we would see, right? So this was something that we recognized was likely to happen, and California is again redoubling our efforts, further investing in strategies to advance equity. And we see now that some of that is coming back together and paying off. But we're not resting on our laurels. And we continue to have a lot of work to do to meet our goals of ensuring that all communities are adequately protected from COVID-19 by the vaccines. So with that, I want to go ahead and introduce my colleague, my very esteemed colleague, Secretary Yolanda Richardson, who is our Secretary of Government Operations, who has really spearheaded a lot of the logistic and operational strategies and really has been a force for equity in our vaccine strategy. Secretary Richardson.
Thank you, Dr. Burke-Harris. So good to see everyone again. It's been a while since I've been here. The last time I came, you all gave me a list of stuff to do. So I've been busy trying to address some of those great ideas that you gave us, and certainly been hearing a lot from Dr. Burke-Harris and of course, Dr. Pan on our efforts. So I just wanted to talk to you a little bit about some of the strategies that we've employed and things that we're doing, and some of the things we're thinking about, and hopefully have an opportunity to hear if there's even more we should be doing from all of you. As Dr. Burke-Harris says, this is the hard part. And we did start to see a divergence in our efforts with the change in eligibility. And so now we have another pressure, which is the reopening on June 15th. We want to make sure that people don't get a sense of, well, we're reopened and everything's back to normal, so why do I need to get vaccinated? So we really are trying to not only get out the word about the advantage and the benefits of being vaccinated, but making sure that instead of having people come to us, which we early on experienced a lot of success with, we want to go to them. So just talking to you a little bit about what we have been working on and what we're doing. First and foremost, and I don't want to take away my next colleague's thunder because she's going to talk to you a lot about dashboards, my favorite topic, and metrics. But one of the things we have done is making sure that we're more transparent about our data so that all of us together could monitor and check our progress and then use that as a barometer for what we need to dial up, dial down, change. And so she'll talk to you a lot about the dashboards and how you all can continue to support us with that. So that transparency has been very helpful in talking about our vaccine equity metric, which is around race and ethnicity and age. Specifically, we've been focused on getting actually down to the zip code level and really starting to look at populations of people and really employing some strategies that I'll talk to you about in just a moment. So, you know, really appreciating, especially our colleagues at California Department of Health, who have just been instrumental in making sure that we are keeping up on that data. We actually meet twice a day to talk about, first in the morning and in the afternoon, to just see each day how we're moving that needle and how we're addressing the needs of the population. One of the things we're excited that we rolled out recently is our Get Out the Vaccine campaign. This is modeled after successful ground level campaigns that you've all heard about, you know, Get Out the GOTV campaigns that we've been doing for years. This is a phone banking and door knocking campaign. We have hundreds of people who are actually calling Californians in these key targeted areas and talking to them about the vaccination opportunity, seeing if they've been vaccinated, and if not, getting them scheduled for an appointment, which is the actual target and outcome of that effort. If the person who answers the phone says, I've already been vaccinated or I have an appointment, these people are very highly trained. They said, well, who else is in your house? Put them on the phone. I want to talk to them too. So they've been very successful in really doing that, as well as addressing some of the concerns that the population has. It's an opportunity for these people to talk to someone about what they might be going through or other services that they might need. Additionally, we have about 2,000 individuals doing what we call canvassing, actually going into the communities and knocking on the doors, talking to people face to face. Have you been vaccinated? And they do the same thing. Okay, if you're vaccinated, who else is home today? Let them come to the door. Let's get them signed up. That has resulted in over 10,000 appointments scheduled. We're going to keep continuing to ramp that up and keep that going. We find that as a very successful strategy. And we're looking at other opportunities to do some wraparound services, again, mentioning that in their interaction, they're finding out a lot of these individuals actually need additional services. Something that I heard from you when I was here is doing a lot more about partnering with our community-based organizations and people who already do this work. And so I just really thank you for highlighting that, because we had an opportunity to go back and really expand from now we have over 480 organizations that we are partnering with. And we've given out over $85 million in doing so to make sure that our organizations are funded in a way that they can use those funds in the way that they know how to reach those target populations. We continue to look for opportunities to partner, and we're just so impressed. Our community-based organizations are not only the people out there, what we say, in the ground game or doing the work on the ground, but there are eyes and ears. We can call them and say, hey, we did this last week. Why isn't it working? Or they can call us and say, this message isn't resonating in this community. So we're really very, very much appreciative, not only for your suggestion, but for the opportunity to work with these wonderful and highly trusted individuals. Another thing we heard from all of you is funding to support the vaccination equity effort. You've seen a lot that we've given out, over $50 million to counties to actually do some of the equity strategies that they have shared with us will work in their communities. We're continuing to give out those grants because we want to fund things such as pop-up clinics in the neighborhood, school-based sites. We want to do more mobile. So as the counties tell us about the unique ways to reach the individuals that they have been working with for many years, we want to make sure that money is not a barrier for them. So we're very appreciative for their willingness to do that and the opportunity to support them in that way. We additionally, hats off to the California Department of Health, a special shout out to Susan Finelli, who's been on the front lines working with our community partners in actually developing equity plans. Imagine that, actual plans that we could support that specifically talk about targeted strategies, when they need to be done, how they're going to be done, and who they're going to target. And so if you all have a chance to go to our website, many of these plans are posted so you can see some of the innovative strategies that have been realized in terms of offering that to the state as an opportunity. And we continue to work with our county partners to ask them, what services do you need? What support do you need? Whether it's staffing, money, information, or even support in their messaging. So that is definitely something we're really excited about. Two other things I'll mention that we've also heard about is at-home vaccination program, something our counties was already doing, but now we have a statewide effort to make sure that we're getting to individuals who are unable to leave their home. They can actually access that information through My Turn, which we're trying to make that tool a one-stop place for people to get information. And if they're not digitally savvy or not interested in using their computer, they can use a hotline to make sure that we can get them connected to someone in their county and get those services to them right away. Additionally, you're hearing a lot about free transportation, and we just heard the Biden administration talk about Uber and Lyft, but we rolled out our statewide free transportation campaign already. And also through My Turn and a hotline, Californians can get a free ride to their vaccination appointment. And something that's wonderful about that is that's also a service that we can wrap around with our GOTV campaign. So when we go to someone and they say, hey, you haven't been vaccinated, how can I help you do that? And they said, hey, I need a ride. Guess what? We have a service that'll provide that for you. Going further than just what I mentioned to you, we're also looking at really focusing the next 4 weeks on just a campaign to get into these neighborhoods. As I mentioned, now that we have the kids and some of them are still in school, we know that the school sites are trusted places within the community. And so partnering across the entire state to set up sites at the school and partnering with school personnel to reach out to parents. And we really appreciate a lot of the enthusiasm that we've been hearing through the leadership of CDPH around this. Looking forward to partnering with pediatricians and family practices. And I think this structure and this effort will certainly position us, as Dr. Pond said, for later on, when the younger kids are eligible. California will already have the infrastructure in place to handle that. So kudos to my colleagues who are on the cutting edge of this. Additionally, we know that the governor has been doing an amazing job of going across the state and talking about California roaring back. And one of the biggest things about that is people getting back to work. So we're going to be rolling out very soon a toolkit for employers that they can use to make sure that their employees have every opportunity and making it easy and convenient for them to get vaccinated. And we're really excited about many of the employers across the state who are willing to work and make it so easy, even whether it's workplace sites or free rides or incentives. There's a numerous amount of things that are going to be coming down the pike in the next couple of weeks to make sure that we get this last group of Californians across that finish line in terms of getting vaccinated. So again, my heart felt thank you to each of you. When I spoke to you last time, a lot of these ideas came directly from our conversation. A lot of you followed up and said, here are some things that you should look at. Really appreciate that. And thank Dr. Burke-Harris and Dr. Pond for their leadership. Thank you so much for having me today.
Thank you so much, Secretary Richardson. That was really fantastic. And I want to now introduce Emily Estes, who is an epidemiologist and data analyst with the California Department of Public Health, and who is part of our amazing equity team. We have a very committed and dedicated equity team to walk through some of the data on equity.
Yeah, absolutely. So I don't have any slides today because I want to be able to walk through the live dashboard and show everyone how to use them while we're talking about the data. So I'm going to go ahead and share my screen. So, let's see, let me make this a little bit smaller. So this is the COVID-19 ca.gov webpage, which I'm sure a lot of you are very familiar with. And the way to access the vaccination progress data from here is either to click on this link or go to menu underneath COVID-19 in your health. Vaccination progress data is here. So the top of the page will say the last time that the data was updated. So for instance, here's the timestamp, May 11th at 4:52 p.m. The data is updated every day, usually sometime in the afternoon. So it usually is pretty fresh, unless if it's ever updated at a different time, it'll say so in the dashboards below. This overview dashboard, I think, sums up really nicely a lot of the different just general statistics that were kind of covered earlier today. So that's the percent of people who are fully vaccinated, partially vaccinated, doses administered across the state, and then doses administered by county. But I think the dashboards that are a little bit lower on the page are the ones that are more about equity. So the ones I wanted to talk more about. So for all the dashboards, you have to click on them first in order to load the interactiveness of the dash. That helps make sure the web page isn't impossible to load. So this is our vaccine status by group dashboard. And there are 3 different cuts of data through which we're examining equity on this page. So there's a vaccine equity metric, race and ethnicity, and age. So the vaccine equity metric, again, I'm sure a lot of you are very familiar with it, but it is a combination of HPI scores from the Public Health Alliance of Southern California and CDPH imputed scores for some other zip codes. And this is a statewide view, but you can also select any individual county to look specifically at the data within any of the counties or LHJs. And then all of the zip codes are sorted into quartiles. So quartile 1, quartile 2, these are zip codes with less healthy community conditions. Quartile 3 and 4 are zip codes with healthier community conditions. And then for each of these quartiles, we're showing the percent of individuals that are not yet vaccinated, that are fully vaccinated, partially vaccinated, and not yet vaccinated. And you can see there's a gradient here, which means that there's still inequitable vaccination rates going on, despite a lot of recent progress in that regard. And then towards the bottom of this dashboard is the cumulative vaccination rates over time. So this is showing for each of the HPI quartiles, the share of individuals that are fully vaccinated among adults, so among the 16 plus population. So for instance, May 11th, most recent date, the data is available, 36.4% of Q1 individuals are vaccinated, and that's the same value that shows up here. So there are two other cuts at this exact same data. I'll show race and ethnicity next, and then show the other dashboards. So I know we want to do a few other things. So this is race and ethnicity, again, statewide. I'll navigate to a county so we can see what that looks like. But again, it's going to show fully vaccinated, partially vaccinated, and not yet vaccinated by group. Scrolling down a bit further, this is the vaccinations by zip code map. So when you click on this map and load it up into a new page, this is going to show a map version of vaccination rates and the HPI quartiles. So for this, there's a few different things you can select, but starting off with just fully vaccinated, let's look at Alameda County. The darker orange shades here are going to mean that there's a higher vaccination rate, and the lighter shades mean there's a lower vaccination rate. And then again, the VEM quartile, these colors correspond with what we just saw on the previous screen. So you hover over a zip code, the vaccination rate will show up, and you'll be able to see what the VEM quartile is. So this is just a little helpful for a more visual approach to the same question. And this information is updated weekly instead of daily. So that's one thing to note. And then the last two dashboards we have down here, this one is a very similar view of HPI administrations, but by total doses administered rather than the total number of individuals. And so the way to read this is that 20% of the doses that California has administered have gone to Q1. And then the very last dashboards down, oh, sorry, there's two more actually. This is the vaccinations over time dashboard that Dr. Palm was showing earlier. So this is a weekly snapshot of all of the individuals who are newly vaccinated each week, what the distribution is of those individuals among each quartile. So for the fully vaccinated, I'll go to the one dose one since that's what. So this is 1+ dose. This means all individuals who are both fully and partially vaccinated. This is the same chart that we showed earlier, but you can hover your mouse over any of the individual dots and get a much better sense of the exact percentages that are showing up each week. And then last, down here, we have vaccination by race and ethnicity, age, and gender. And so this shows the share of doses that are going to each of these groups. I know that we wanted to cover too the view of data that is cut both by, that shows different combinations of age and race and ethnicity. So I'm gonna stop sharing so that we can pull the slides back up. And Bobby, maybe you have those.
Yeah, we're going to pull it up right now. Thank you. Slide 24. Now let's go to the next slide. We'll catch it. There we go.
Perfect, thanks. So this is the 1+ dose. So again, fully and partially vaccinated combined. Vaccination rates by race, ethnicity, and age combinations statewide. So one of the things that I think a lot of people notice right off the bat here is that a lot of the vaccination rates are above 100%. And that has to do with just, it's really difficult. The census data does not always accurately measure groups, especially with smaller population sizes. So some of these are going to appear larger than they should be, just because of the different denominators that are used to calculate those populations. So this is a few different age categories ranging from 12 to 19 to 80+. And this kind of shows the distribution of vaccination rates within each of those age groups by race ethnicity categories. And one other thing to note here is that this does not include vaccinations that don't have any race or ethnicity tied to it. So if the race ethnicity was not reported, and it also does not show anyone who marked other, since we don't have that denominator data from the Department of Finance's census information. I just saw in the chat a question about the American Indian and Alaskan Native data. Part of that comes from CARES, of the state reporting database, and then part of it does come from IHS. The federal government just started reporting, just recently started reporting doses administered by federal agencies by zip code. So we have that information now. And I'm happy to answer any other questions about this or any of the other dashboards.
Great. Thank you, Emily. Our time is short at this point because we have a special guest for the next section of our agenda. So I'm going to let Denny ask one question, and then we'll come back to this if we have time later. But please, I know a number of you have put your questions in the chat. Please put your questions in the chat, and we will do everything we can to get them answered in writing. Go ahead, Danny. Danny, introduce yourself.
Thanks, Bobby. Denny Chan from Justice and Aging. Always hard to think of one question since I have several. But first, thank you for getting us the data. I've been a broken record at multiple meetings, and it's great to finally see the beginning of this piece. And so big thank you. I know it's a lot of work, and you have a lot of data requests and priorities. So thank you. I think if I had to choose, my one question would be that at least looking at older adults 60 and plus, so 60 to 69, 70 to 79, 80 plus, you almost see two different worlds. You see a world that's well over 80%, depending on what the group you're looking at. And then you see numbers that are frankly like 50% and lower, sometimes even lower than 40%. And these are people who, for the most part, have been eligible since January. So to Dr. Burke-Harris's point of like, it takes time. I know it takes time, I understand, but also we've given a lot of time. And so I understand that there are some, zip code specific strategies, GOTV kind of strategies. Can someone speak a little more on how do we fill the gap specifically for Latino, Black, and American Indian, Alaskan Native older adults who we see just really since January, right? They've been eligible, but we just aren't there yet. How do we make sure that we're not describing two worlds, but one world moving forward? That would be my question. I have a lot of other questions, but I'll save them for the chat and offline. Thank you.
I can start.
Okay.
I think
go ahead, please.
Of us who have a lot to say about that, Jenny, I appreciate it. To Dr. Burke-Harris's, this is the hard part. In different populations we've learned, and based on different backgrounds, whether it's financial or even where you live, it can be very difficult and harder. I hate to use the hesitancy word because I think that narrative sometimes can have a chilling effect, but it can be definitely harder for those individuals to come around. I use, as an African-American woman, it took almost threatening for some of the older adults in my family to get vaccinated for various reasons. And what I will give kudos, definitely kudos to our GO's office, is their change in tweaks and messaging. They're definitely looking at what they call rumors, things that have been impeding some of our older populations in getting vaccinated, things that they think the vaccine will do to them. Their historical context about immunizations and vaccines overall that they've been carrying around for years, and messaging that really speaks to them. The second thing that we've heard is that messaging needs to come from people that they believe really understand and they can relate to. And so you've seen a lot more people other than just us talking to those communities about the vaccine and actually watching those people get vaccinated. So you've seen older African-American people on TV getting vaccinated. You've started to see more things happening in churches where a lot of these individuals go or have trusted relationships with. So we are doubling down in those efforts. And as I mentioned, some of the other strategies, even using those to wrap around to definitely continue to reach those populations. So we agree they stay first and foremost on our hearts and minds, but we are definitely seeing that they need a different type of approach. And we hope that the ones that we're doing will certainly start to see some movement in those areas.
I'd just like to add that if you all have suggestions and recommendations for additional strategies that you think might be helpful, please feel free to let us know, to send an email to Bobby, and we'll get that information and work it through with our teams.
I know we could continue on this topic for a long time because it's so important to all of us and there's so much to discuss. I do think we need to move on, Nadine and Erica, to introducing Lisa and Margot.
Yes. So I'm very, thank you for keeping us on track, Bobby. I'm very pleased to introduce Lisa Hershey, who is a member of our CVAC and also a leader at Housing California, who will introduce our special guest to talk about vaccines for individuals who are unhoused or living in public housing. Lisa, thank you so much for bringing this resource to the CVAC.
Thank you, Dr. Burke-Harris and Dr. Pon and Bobby for making this experience possible. This has been such an incredible journey over the past year being a part of this task force, and we really appreciate the space to share today. I know that Bobby sent out Dr. Margot Kuchel's brief bio to you earlier, but I just want to take a moment to acknowledge all the great work that Margot does. And I will say Dr. Kuchel wears many hats. She is a professor of medicine at the University of California, San Francisco, director of the UCSF Center for Vulnerable Populations and the UCSF Benioff Homelessness and Housing Initiative. She's also a practitioner and doing general internist work at the Zuckerberg San Francisco General Hospital. On top of that, Dr. Kuchel also does incredible research that focuses on the causes and consequences of homelessness and housing stability with the goal of preventing and ending homelessness, and talks about a home as being the #1 prescription for health. And this has been totally proven again and again with our COVID-19 pandemic. So excited to have her share that. She works really closely with government bodies, nonprofits, and communities impacted by homelessness to bring forward solutions that center racial and housing justice. She serves on many boards, et cetera. But I want to finally note, and the reason why I really wanted to bring Dr. Kuchel together with all of you today is she's been an incredible partner, mentor, and someone who, and a board member for Housing California, but someone who actually goes on the ground to try what she's testing. So she has led me and led us on this journey over the past year on how best to meet the needs of the people we care about deeply, people experiencing homelessness, people living in unhoused conditions, people experiencing housing instability, and trying all the different ways to make this work from testing through vaccination to sustainable infrastructure. So with no further ado, Margot, I'm going to hand it to you.
Thank you so much, Lisa, and thank you all for inviting me today. I'm going to talk briefly just some things that we've learned both from our practice, trying things, from research and from conversations with folks working in this space across California and across the country, and hopefully we'll have time for a short discussion. Next slide. So just some level setting. Homelessness is common. We know in California about 160,000 people are homeless each night. And in California, 72% of those are unsheltered. We've seen across California large-scale outbreaks in our sheltered population. And just to always remember that particularly Black Americans, Native Americans, Pacific Islanders are dramatically overrepresented in the population of people experiencing homelessness. Next slide. So the homeless population is aging, which actually brings us an urgency to the issue of vaccination. And estimated approximately half of single adults who are homeless, so this isn't moms with kids or parents with kids or homeless youth, but among the single adults, about half are 50 and older. And we've observed dramatic premature aging, such that at the age of 50 or 60, people physiologically and sort of in terms of their health conditions seem much more similar to people in their 70s and 80s. People who are homeless have a much higher prevalence of comorbidities that are known to be associated with severe COVID consequences, have poor access to healthcare, high prevalence of medical mistrust based on experiences of racism in the health system, experiences of stigma related to their housing status and substance use status. This leads to complications when we start talking about vaccines. And people who are homeless live in a variety of environments. And when we talk about them and we talk about vaccine campaigns, we should talk not only about those who are homeless, but those who are living in single room occupancy hotels, who are housed, but often at very high risk of COVID. All of the individuals who used to be homeless who are now living in permanent supportive housing, the large number of Californians who were moved successfully into shelter-in-place hotels and trailers, those living in shelters and those in unsheltered environments, all present different challenges when we think about how to get this community vaccinated. Next slide. We think about certain principles as we began to design campaigns. We think about the barriers to acceptability, mostly due to medical mistrust, again, due to experiences of racism and stigma, as well as lack of access to accurate data. And then barriers to access, which are myriad: lack of access to healthcare, transportation barriers, lack of access to phones or internet, making it impossible to sign up for an appointment. And perhaps most importantly, the competing needs. When you're homeless, you're trying to think about day-to-day survival. It's hard to make plans or accommodate things that take longer term, have longer term benefits. But I think if I could say one thing, it's not to confuse a lack of access with lack of acceptability. I think it's easy for us to say, to sort of call on mistrust and acceptability, but all of our research has shown in this community, when there are low rates of vaccination, it has much more to do with access than acceptability. Next slide. So in terms of guiding principles, I wrote a piece with Bobby Wath and others at the National Healthcare for the Homeless and BMJ a little while ago that really just spoke about adopting a tailored approach and committing to being trustworthy. And if we can keep those things in mind, we can get this population vaccinated. Next slide. So when I talk about adopting a tailored approach, and this, by the way, is one of our big vaccine events that we do in the Tenderloin District of San Francisco, we really want to adapt messaging that will promote confidence and that's tailored to the needs of this community. We need to really take seriously the competing demands that this population faces and how difficult their day-to-day lives are and make it as easy as possible to get vaccinated. To do that, we really need to bring vaccines to right to where people are. We need to use trusted partners, such as community health outreach workers, people with lived expertise of homelessness to guide our efforts. And that is time and time again, the most effective way to make this happen. And we want to create multiple opportunities and offer repeated attempts to get vaccinated, because what we're seeing in California and around the country is the first time you, for instance, go into a shelter or an encampment, maybe 30% of people, even using best practices, will take the vaccine. But when you come again and again, you can get those numbers up to 70, 80%. Offering incentives have proven to be extremely effective in this population. There's a lot of discomfort around this idea of coercion or whatever. All I could say is it works. We hear it right from the folks we're talking to that gift cards, food, other small gifts can really help move people from ambivalence into accepting vaccine. And we really need to think about providing support for symptomatic reaction, particularly for the 2-dose regimens. A significant percentage of people feel pretty miserable. And if you're housed, and that means filling up in your bed with a heating pad and, to deal with the chills, that's one thing. If you're actually going through that and you're outdoors, there's a whole bunch of different things we need to think about. And you can think of the chilling effect on those around you if people are watching someone suffering without support. So we really need to plan for that. Next slide. When I say commit to being trustworthy, this is a population that at every turn has experienced good reasons to not trust us as a healthcare system. And I think we really need to put at the center of what we do a commitment to be trustworthy, to be good to our word. We have found it very useful to reach out to communities in advance to discuss vaccinations, to listen to their questions, to taking those questions seriously, and to giving honest answers, not trying to sugarcoat the fact that people might have a vaccine reaction, being very honest about what the data shows, to be able to listen and respond to concerns, treat them seriously, and answer them in a straightforward way. We have been hiring, training, paying community health outreach workers with lived expertise. These folks are brilliant and have been absolutely essential to everything that we do. As I said, be upfront about possible side effects. If you understate it and then people see it happen, we've lost our trust. and then to perform and provide informed consent and choice. And I will say this has become even more important after the J&J pause, to really be able to have serious discussions with people of what we know, what we don't know, and to discuss all data truthfully. Next slide. So we started to do research before the vaccines were out, knowing that they were coming. And what we found over the summer was that about the same proportion of folks who are experiencing homelessness expressed interest in vaccines as we were seeing from national data at the time. We surveyed my cohort of older homeless experienced adults. 80% were Black African American. These were done in July and August and September before the data from the studies or the EUA. And 50% said to us then that they were very or somewhat willing to get the COVID vaccine were it available that day. In October, we did a large-scale testing event in the Tenderloin district of San Francisco, and 70% were very or somewhat willing to receive it were it available that day. This was before the EUA data. This was higher than the general population at the time. Both of these sets of interviews we did prior to the efficacy data and the EUA. Next slide. We did a fair amount of qualitative research in a variety of settings, streets, shelters, older folks, younger folks, and we heard the same things as we probably heard from the general community. The motivating factors for getting a vaccine, what really rose to the top was one, family reunification. People talked about wanting to hug their loved ones, wanting to be able to see their loved ones again. A strong sense of civic responsibility. Again and again, we heard from people that they felt like it was their duty to help vanquish the virus, and a yearning to return to normalcy. When we asked what the concerns were, a lot of people, like in the rest of the population, said they didn't want to be first, they didn't want to be a guinea pig, they really wanted to see the data. There was a pretty widespread concern based on experience with other vaccines where they had seen side effects and took it to mean that people were being injected with the virus of the vaccine. They really wanted reassurance that we were not going to vaccinate people with the COVID infection itself. And we heard a general mistrust of government and in a sense, interesting, we heard a lot of trust in healthcare providers from people, but maybe they knew that they were talking to UCSF, but a pretty overwhelming mistrust of the government as an entity. And they didn't really want to hear from the government. Next slide. We have done a lot of vaccination efforts in shelters and shelter-in-place hotels. These we've generally done as venue-based events where we brought in community health outreach workers, and then we've come back and then back and back again. We use trusted staff and chows, use some light incentives. I know in San Francisco, the Department of Public Health has not wanted us to give monetary incentives. We've done things like socks, care packages, and others, and just needed to come back again and again and again. And I'm hearing this from all over the country, that don't get discouraged if your first visit, you're only getting 30% of people accepting it. Next slide. For folks who were either living in SROs, living unsheltered, or living in permanent supportive housing, we've been using a variety of methods. We wanted to get as many people as we could to mass vax events because that's less resource intense. So we were using providing transportation, community health outreach workers were going, helping make people appointments and bring them. We've been doing a series of neighborhood low barrier events where nobody needs to sign up in advance, where we use our community health outreach workers to answer questions, spread the word, advertise widely, but the appointments themselves are drop-ins. And then we have been doing roving vaccinations where we're just bringing vaccinators to street corners, into lobbies of SROs, into encampments, wherever we need to go. And that has been slower, but highly effective. I think the key factors through all of these is the use of these community health outreach workers, making these events as absolutely low barrier as possible, and providing incentives. Next slide. Some additional concerns that we need to think about. The technology is a bit of a bear. We've been using primary health with portable Wi-Fi hotspots and tablets to do it. Many people don't know if they've been vaccinated before, so having someone who can actually check the CARES record has been essential. We've been using our chows to remind people of a second vaccine, and I'm really pleased to say we're getting about 85% people coming back 4 weeks later, which, to be honest, shocked me. We've been trying to do this mobile access, and there's a lot of questions of can we add this information to things like HMIS, the Homeless Management Information System, because lots of people are approaching folks and it's hard to keep track of who's gotten vaccinated. And then we tried to put some thought into support for symptoms post-vaccine, giving people care packages with Tylenol, ibuprofen, and then talking about setting up in some places, setting up cots and other things that people can come and rest. Next slide. In general, we found the one-dose regimens have been preferable. Right before the pause, I had this great sort of natural experiment where we were giving J&J a vaccine. We miscounted and thought we had more left than we did. So we wound up with about 18 people in line and we were out of vaccine. We, in the principle of being trustworthy, all got on our phones and called everyone we could to find vaccines, and we got lift tickets to bring people to vaccinations. And the first people we were able to do is I was able to locate vaccines at San Francisco General Hospital. I offered them to folks waiting in line, and their first question out of their mouth was, which vaccine is it? And when I told them that it was Pfizer or Moderna, to a person, they said they didn't want to go. And I explained I wasn't sure if I could find J&J, and they said, that's okay, we'll wait. And we called around, we found J&J vaccine and got people to it. That was right before the pause. We just started using J&J last week, and we offered a choice. We had Moderna and J&J. We did informed consent to every person, and out of about 80 people, 3 or 4 chose Moderna. The rest actually chose J&J, even though we sort of described it. There was a pretty strong preference to the one-dose regimen. Early, we don't know if that will hold, but that's been our experience. Next slide. So final thoughts, access is really a bigger barrier than acceptability. We need to take acceptability seriously and tailor messages. We really need to bring vaccines to where people are, create numerous opportunities. A no is a no for now and not necessarily a no. Don't assume a lack of uptake is due to a lack of interest. Be trustworthy, create opportunities to answer questions. We really need this workforce of community health outreach workers, peer support. Using incentives makes a big difference, planning for symptoms, and it appears even after the pause that the one-dose vaccine regimen continue to be preferable. Next slide. I think that is it. Here's my contact information. I'm happy to take questions.
Margot, thank you so much. We should have allowed 2 hours for this instead of just a few minutes. Unfortunately, I don't think we have time for direct questions for you. I wonder if you would mind, if anyone has a question or wants to engage with you, if they would email you directly.
Of course, that would be fun.
I think that's what we'll do in order to leave time for our last agenda item. I hate to cut this short, but thank you so much for making your experience available to all of us.
Thanks for having me.
Thank you so much, Dr. Kushal. And now I want to move forward to our outreach and community engagement update. And we will start with Emilio Vaca, who is part of the CDSS team. Emilio, are you on mute?
Oh, yes, I was. You think I'd learn by now, right? Emilio Vaca, good afternoon, buenas tardes. Really excited to be back. I know it's been a while. I think last time I was here was in January when we were first talking about what we were going to do for outreach. So really excited to come back and share a little bit of what we've been doing. Want to just lift up all the great work that's happening across the state, and obviously just all of the folks and members that are part of this committee, just the advocacy and making sure that we continue to stay upright and honest in all the work that we're doing. And so what I wanted to do was walk through a little bit of a metrics conversation of what we've been doing on the ground and just with the outreach efforts. So do you mind going to the next slide, please? I just want to remind folks that when we came early, beginning of the year, we were the 2 different cohorts that we were working with. One was with the Labor Workforce Development Agency doing workers' rights education and doing harm reduction. And the other was the Department of Social Services, really wrapping around other additional services that community members may need, example, information on housing or paying the rent or food services. And so as things evolved and vaccines became available, we were really fortunate to have a lot of our partners pivot to incorporate and make a priority talking about vaccines, obviously still doing harm reduction education, as well as providing those resources or information to those resources available through the state. So what you see here is all of this work started back in February, and I was, a lot of our intentionality came from the conversations we had with all of you in January, learning from the census model, also just other projects that have been going on around the state during the start of this pandemic. And so we took to heart everyone's recommendation, thoughts and suggestions. And so as we built out the framework, we didn't just want to do a bunch of social media posts. We didn't just want to do a bunch of emails, and we wanted to be really be interactive to the best of our ability. And so we really focused on our contracts with our partners to look at some interactive, what we call interactive tactics, which was phone banking, door-to-door, text messaging, one-on-one, and obviously canvassing, meaning through booths, tabling, community events, etc. And so when we looked at phone banking, I'm really excited to share that we've had over 1 million phone calls made across California. These are phone calls that are happening obviously prior to what Secretary Richardson mentioned with the Get Out the Vaccine efforts. These were all started off with harm reduction and leading into what is vaccine education. And so other things that the partners have been doing has been knocking on over 90,000 doors, which has been really insightful to learn a lot of the questions that I heard today. What are the things that we're hearing now in the community when it comes to harm reduction? And I'm going to be excited to share out who's going to be presenting on some of the work here after these slides. So these slides have already been available to you. I'll just make sure that I run through this so we can give time for our speakers. The next slide, please. As I mentioned, a lot of this effort really started off with harm reduction, and we've incorporated vaccine education. I'll focus on the last bit of this slide, this table here, which is labeled vaccines. Our partners have been able to do two types of vaccine connections. One has been on the facilitated and the other has been referrals. And those numbers are represented through the following. When we say facilitated, that means they were able to create an opportunity either through MyTurn or any other local health jurisdiction platforms. This is obviously before all the counties jumped on to utilize MyTurn, since we started this in February. As far as referrals, that might have been options that perhaps those counties that were not part of MyTurn, that partners were able to help refer community members to those specific platforms. And so what I wanted to do is, as I mentioned, we had over, as far as facilitated, it's still going, it's still growing. It's over 120,000 direct appointments through MyTurn or other local health jurisdiction platforms. And that's really exciting because a lot of our effort has been really on education. And just like Secretary Richardson mentioned is, we're not leaving any stone unturned and making sure that while we're there, if we're in an event or at a booth, or if we're doing text messaging, that folks are getting the same message across the board, and that we're consistent in our messaging and working closely with our communications team. And there's some members that are some of the CVAC members that are also part of the network, and we're really excited to see that continuation of the work around equity. And I know back in January we talked about we really wanted to be intentional about the populations that we wanted to reach out to. So this work is still continuing as we speak, and I get the privilege and the honor to introduce two of our community partners that are, I know as a state we could talk about all the great stuff that we're doing, but it's always more valuable to hear directly from the partners who are on the ground. And if you don't mind going to the next slide, please. I want to introduce my brother from another mother, from a different color. Sometimes depends on how much sun I get. Deep has been really involved in supporting outreach in our from our what's called the CWAP, doing work with our labor workforce development agency and doing outreach to workers. He's going to be, talking a little bit about the work that they've been doing, the populations they've been serving, and also the geography that they've been doing work in. And so I would love to turn it over to Deep. I know he has some slides to share as well.
Thank you so much for that introduction, Emilio. Let me pull up mine, and it is quite an honor to be able to share with my fellow CVAC members. And is everything good? At least on my screen, everyone can see it. Perfect. So I'm going to take 1 second to share about our logo, because we were very excited about it. What we had an opportunity to do, as Amelia shared, is really kind of team up with the California Labor and Workforce Development Agency, really in an unprecedented project during an unprecedented time, and it really gave us an opportunity to center those essential workers that we knew have been of the most affected. UC Davis has put out reports, UC Merced has put out reports, especially about the infection levels in the meat and poultry industry. And so we knew this was a community that we really wanted to target. Being from the Central Valley myself, we knew that primarily those that work in the industry tend to be from Latinx backgrounds or Punjabi speaking backgrounds. Although there's, especially in Merced County in the city of Livingston, you also have increasing number of Hmong workers, and I'll touch a little bit about that as well, as communities that we've been especially working with. Just to quickly again about the demographics we're talking about. Oftentimes when we talk about the meat and poultry industry, we have visions of the Midwest, but really, here in California, it is the Central Valley, where we see a number of different industries, a number of different, extremely large, because of the consolidation in the industry of the processing plants, and very, very early on in the pandemic, and the data seems to kind of really conclusively show how evident the infections rate were, especially amongst these populations. As Amelia shared, we were working specifically in the San Joaquin Basin, the sort of northern San Joaquin Valley, really from Stanislaus, Merced, and Fresno counties. So what did we find out? Our activities were just as Amelia shared. We were tabling, we were going door-to-door canvassing, really snowball phone calls where we would be able to have an initial interview, and oftentimes they would share family members that were working at Foster Farms, Cargill, Pittman Farms, Harris Ranch, a number of these very large sort of industrial scale meat and poultry plant industries. We were canvassing in front of the work site, asking people if they needed a vaccine, but also connecting them to other resources that the state has provided, for instance, around housing assistance. What did we find was effective? Just to the same points as the previous speaker said about kind of giving awards or giving prizes and incentivizing. For us, to be honest with workers, it was really just providing PPE. Because more often than not, employers have made workers purchase these things themselves. And so just making those things available were profoundly appreciated. Making sure that we were talking to people in language specific to our project. We were focusing on Punjabi and Spanish. We created WhatsApp groups, and really just going door to door in Livingston, in Turlock, in parts of Fresno, in Sanger, creating brochures, making sure that people were aware of SB 95, that, workers have the opportunity to take 80 hours off due to COVID. Many workers, and especially temp agencies, were not providing this information to workers, and especially with the temp agency. And that's something I may want to return to. In fact, we had a number of different complaints where temp agencies were even denying the existence of SB 95, really putting in jeopardy both workers, but also their colleagues. We were holding small town halls in apartment complexes, especially because the most elderly, and that's a different group that I want to just kind of take 1 second on, is elderly immigrant workers. So not just the elderly, not just elderly immigrants, but specifically elderly immigrant workers, as very specifically sort of very marginalized, very vulnerable population. We found oftentimes, especially in Hmong and Punjabi, that employers rarely had any translators. Workers shared they've had friends that have been fired without really even understanding what exactly occurred or even how to defend themselves. And a lot of the requests we were getting were specifically around EDD, paid sick leave, state benefit documents, and really just kind of how to navigate the process. So I know in 5 minutes I've sort of covered a lot. We'll maybe get an opportunity just to share some questions, but my contact information is on the bottom, and I just really want to appreciate the state, LWDA, of course, Emilio's team, and really those that have been leading the efforts. We've had these amazingly bold young women that have been so fearless, advocating for their parents, advocating for their tias, advocating for their family members to make sure that these labor rights are being centered and that this information is going out to the public that most importantly needs it. Thank you.
Thank you, Dee. And I'm sure there'll be some follow-up and some questions on the chat here, but I also wanted to give some time and space for, I was really excited to hear when we brought on our next presenter, the Sacramento Urban League, with Ms. Cassandra Jennings, and wanted just to give some space for her to also share out some of the things that they're learning and they're finding, and just sharing out what they're hearing. So welcome, Ms. Cassandra.
Thank you. Thank you very much. Thank you, Dr. Burtz, Harris, and all of you for your commitment to this very important issue. And I will say, although you only have one more meeting left, I'm glad to be here in this meeting to share. And certainly we have a lot of meetings ourselves. We are a provider as well as we are a lead in Sacramento County and the greater Sacramento area. And I would say that coming together with 21 of the participants in the program has just been great because we've been able to share information. I heard somebody talk about transportation. Well, in the conversation, somebody said they needed transportation. We said, here are 50 Lyft codes that you can use for your people. So that sort of cross-pollination and support and collaboration on the region was great. But locally, as far as our outreach, we've done many of what you talked about and you've heard. We've done the virtual, on the ground and around the town. We have done broad outreach, and I know because we think it's there's multiple steps because you got to keep messaging the same thing, and then it resonates with people, and then they have the information they need. So we started out broad because, as we've heard already, we need to educate. We also needed to deal with the hesitancy and really using influential and trusted messengers. And we really had to deal with the accessibility because our communities were late to get it. And then now we're also dealing with convenience and flexibility, which I have some information. But, we would do mass emails and very targeted to our community, as well as social media. And it's interesting because then I would follow up with somebody and say, didn't you get our email? And they were like, is that for somebody else, And it's like, no, that was for you to come to get educated, to then hopefully have the information you need to make the right decision. But what we decided also to do in the broad sense is we are doing a series of outreaches, and we're calling them Immunity in Community, and there are 3 components. The first one was comedy, immunity in the community. The second one, which we had Friday, was gospel, immunity in the community. And the next one next week is going to be jazz, immunity in the community. And you say, how does that all fit together? Well, in the comedy one, because we're all like shut in still a while back, and it's just to give some relief. And then we had Dr. Janine Barra as the doctor. And then we had a conversation because real talk is important for our community. And as we said, trusted messengers. And so that was really important to really sort of dispel a lot of the issues in the community. And then the next step was the follow-up, the text messaging, the calls, and to get them to the vaccine clinics, which we ended up having one. And that was about the accessibility, because once you get people there, and a problem in some of our communities is that then they come and then they were like, well, can I tell my friend, my cousin or my friend, and will you be here next week? And we're like, no, we need to get back to you. So the accessibility is good, and obviously the convenience in the community and the flexibility, which we experienced just this Monday. But then the next one we had was gospel immunity in the community. And of course, we had a pastor because he's a trusted messenger, a huge congregation. You can outreach to the lot, well respected, outreach to other pastors and others. And then we also had Dr. Olivia Kasiri, who's our public health officer, who really gets the real talk. So she's like saying, oh yeah, this is, I forgot the word that she used. I had it on the tip of my tongue, but this is real. And then she thought vitamin C is not gonna do it. You know, if you think that's gonna do it, that's not gonna be the answer. And then we had a young person, because the young people are hesitant and they are spreading a lot of things or understanding things differently. And so she was able to ask questions and then get conversation. And then of course we had the gospel singing. And so as we come out, people were enjoying it. So that was important. Let me just say, we wanted to connect the education to the accessibility and the consistency. So we were able to have a vaccine clinic with Dignity Health. And we had one with Pfizer right after they pulled Johnson & Johnson off the market. And then we said, sorry. So then after that, we had the second one. And instead of just saying it was the second, we opened it up to more people without either reservations or without, so with the J&J. And we thought, well, how many will come? How will that work? If we can get a few, if we can get 40 or 50, that's more than we would have had before. And literally with the flexibility and the access and certainly the consistency, we were able to get even more people in on the second one of Pfizer. And then when people would come and they said, oh no, I really don't want J&J, I want Pfizer, we were able to get Pfizer. So our outreach has been broad and then narrow. We do one-on-ones. We are a workforce development organization, so we have been very busy during this COVID time. We outreach to over 4,000 people to get them ready for jobs, to get them into training. So we have great outreach and opportunities to really connect with people in our community. So we are fast and furious. I will say, we are also using the media. So we go on the radio, which is owned by California Black Chamber of Commerce, and we have Real Talk. And I know that there have been ads that are purchased and all that, and we hear them. But when we get with Lee Perkins and we start talking to the community and about the community and bringing on those trusted messengers, we are connecting and enforcing the sort of messaging that occurs out there. And then when we did our last vaccine, they were like, we heard it on KCRA. And we're like, well, how did that happen? Well, they're on our mass mailing list. They are communicating with our community too. And then our site is being accessible to the people. So we're obviously, it's hard work. You heard, it's not one method fits all. And because we're on the ground and serving our community, we're doing everything we can to make sure people have the information to make their best informed decision.
Thank you, Ms. Cassandra, and thank you, Deep, for both sharing the work that's happening on the ground and some of the lessons you're learning, and also the things that you're hearing. And I know that I know we could spend the whole 2 hours just talking about everything that's happening by partner, and I'm just so thankful for both Deep and Ms. Cassandra for taking time to come and share the work that they're doing. And I know that we still have other presentations. So if there's any specific questions for either Deep or Ms. Cassandra, please put them in the chat, and we'll, they could follow up, and maybe they could put their contact information on the chat as well. So I will pass it on to my colleague, Martha. Dr. Dominguez, I'm talking about a research update.
Yes. Good afternoon, everybody. I hope everybody's doing good. And those that were our mothers or stepmoms or caregivers, happy belated Mother's Day. It's always nice to celebrate a special day. We can go to the next slide. Thank you. Just wanted to give you guys an update. I think we have shared in the past that we are doing a quantitative formative research. It's really a monthly tracker where we're tracking our various progress. And what we're seeing is some improvements with our engagement. And there's some areas that we need some improvement as well. And then there's some potential sort of areas that we can recalibrate to ensure that we reach, our key communities. But just wanted to give you guys some top line key facts that we have found out. One is that we have learned that our campaign through the Department of Public Health has increased and has really gained some positive perceptions on the vaccine rollout, which is really important because when we disseminate messages, that really indicates that the people are trusting and see us as a trusted source, as a trusted messenger, providing that information. We've also seen a vaccine uptake and acceptance has increased and resulting from the decrease in vaccine from the undecided. About 78% really do recall or some type of element of our vaccine campaign. And we test various different elements, whether it's the messaging, it's the taglines, the call to action, various different elements to understand if people are remembering our ads or recall that information that is being presented to them. And about 3/4 of them do. Next slide. Some of the challenges that we're seeing in the next months, and we're already making some calibration and improvements, is really, we do know that we need to continue working on engaging the African American community, the Latino English bilingual community in terms of overall vaccine information to reach acceptance. Spanish dominant are largely unfamiliar with CDPH, and that's for various reasons, but we need to continue to promote that and really make that connection so they can really engage on our messaging and really leverage that trusted messaging element, hindering the effectiveness of the campaign. Side effects has been one of those prominent items that consumers have really brought up, particularly as a result of the J&J pause. It is an area that we've been getting a lot of questions, even on our social media. People have a lot of questions on short-term and even long-term side effects. In terms of political affiliation, we wanted to kind of get an understanding in terms of what role it played. We have uncovered, and I think some of you may have asked us a couple of meetings ago if we were tracking this, so I wanted to present this, is in terms of rejectors, which is a little bit more hard for us to convince, skew more Republican, and in terms of supporters, meaning they're more likely to get vaccinated or have been vaccinated, are largely Democrats. We're continuing to monitor this political affiliation as it plays out, given that political affiliation or just the political climate as the start of the campaign had a huge role in how people perceived the vaccine as a whole. Rejectors continue to be unconcerned about getting COVID, and that's just the mistrust of sources that through their personal friends or physicians or family and friends still are harping on the conspirational beliefs, or also maintaining that they're right not to get vaccinated. So we're not really, we're not thinking that we're going to fully convert the rejectors, but we're hoping that some of these supporters do help us convert some of the rejectors and really understanding that information. Undecided are still saying that they're having to get an appointment versus walk-in, which is inhibiting their vaccination. I know that's some of the work that we are doing, and Yolanda talked about it. I'm doing more of these walk-ins, so that is a really good element for us to get more of these undeciders, or even those that are supported that haven't gotten vaccinated, to get vaccinated. We know that walk-ins are a really nice motivational element that can help people get vaccinated. Where we're going to be focusing with the campaign and in terms of our messaging, we want to make sure that we continue to underscore the side effects, both whatever we know based on data. We want to underscore the safety and the effectiveness of the vaccines, the science behind the vaccines, the clinical trials that was part of it, and also just underscoring the testing and approval of vaccines through the FDA. We're going to continue to deliver our messages. We're getting even more creative. Social, internet, medical offices, personal physicians, family and friends. We really are wanting to equip everyone around us to ensure that they can help us amplify the messaging within our communities. We really want to increase the awareness of CDPH. As I indicated earlier, it really helps us build that trust with the community and really make us solidify us as a trusted source. The department traditionally does have a good reputation and historically with the community, but with vaccine, we're trying to hyper that in a way that allows us to really become that reliable, credible source. Next slide. Next slide. There we go. So we'll continue to track our information, and we're doing that on a monthly basis, as I indicated, but some of our findings have led us to produce a couple of creative ads. I don't think we have time to show you all, but I did want to show potentially two, one with our Dr. Tomas Aragon from our department, who's answering a question to one of our consumers, indicating the hesitancy in particular among the Latino community. And then this moment is our latest creative video. We have that both in Spanish and English. And then for your leisure, we are also providing a partnership that we did with Fire Foundation, something that is also rolling out, in particular in rural areas, and engaging our different organizations to help us elongate the messages. So Bobby, I think you were going to help me play Dr. Aragon's video, which we were really excited to have, and then this moment.
Yep, here we go.
Sometimes they say it might work, it might not work. And so I ask myself the question, like, why even get the vaccine if it can also harm you? For me, it's like taking a 50-50 chance.
Hi, Andrea. Some say that the vaccine is harmful or that it might not work, but that's not true. Millions of people have been vaccinated with no ill effects, and I can tell you that getting the vaccine is far safer than not getting it.
That was our question and answer, and this is a strategy that we're using. It's similar to a testimonial where we had consumers submit questions.
This is about how cool of things. Hey there, little guy.
Go ahead, Bobby.
Let's get you to this moment.
Is that it?
Yeah.
Of relief.
Awesome.
Protection.
Just got vaccinated.
I just got vaccinated.
No, just got vaccinated.
Hope. So that we can get to all the other moments. Let's get you to the exhale you didn't know you were waiting for. Let's get it together so we can be together. Let's get to immunity. Now's your moment to get vaccinated.
Thank you, Bobby. Yeah, and we also have this piece, as I mentioned, in Spanish. So please take a look at it. I know the slides have become available, but you can always go to our campaign website, which is the Vaccinate All 58. We have tons of other testimonials that we're rolling out on social media. And if you haven't followed us, please do and help us repost the messaging. Other than that, thank you for your time. I'm happy to answer any questions.
I think we're going to go on to Maricela and the next slide because she has a couple of very important comments to make before we go on. Maricela?
Great, thank you so much, Bobby. We'll go ahead and go to the next slide. So just as some folks have already talked about, we've had an anticipation of having eligibility expanded to 12 years old and above. We've been working to launch a campaign that's specifically engaging families about this expanded eligibility. So just wanted to highlight a couple of things that will be available and that we've been working on. One is that just in a similar fashion, when we launched the original campaign, we're going to start with facts-based messaging. So folks know, one, that eligibility has been expanded. The vaccines have proven to be safe and effective based on trials. And we're going to be doing that in a number of ways. One is, really a robust effort around earned media, engaging reporters. We actually had Secretary Galley And Dr. Pan earlier this week kind of walked reporters through the process. We're going to continue to engage press, especially ethnic media, on how we're rolling out this expanded eligibility and how families can make an appointment. We'll be starting with some paid media that's really focused on digital, paid, social, and radio. And so we have some assets here for you that will be made available starting tomorrow on our toolkit website. We can share with folks after the meeting today or tomorrow as we roll out the toolkit with our other partners as well. We're leveraging the existing network of partners that we have, including our CBOs, but have also started to engage other partnerships that are really based on the education community, and both from advocacy and CBOs that engage on the education front. So really expanding the pool of trusted messengers that can help us communicate and engage families about this exciting news that now we have vaccines that are safe and effective with the Pfizer vaccine. As I mentioned, we will have a toolkit that's available for our partners starting tomorrow. We will ramp up mid-June and expanding what we do on paid media. I think someone may have mentioned earlier in this conversation, but My Turn is also going to be available for folks to start making appointments as early as 8 o'clock tomorrow morning. And as well as the COVID call center. If you don't have that number, we can make it available for folks too. But again, all of this will be provided in our toolkit. So exciting news. We hope that we can count on your support as you have helped us in the past, really help spread the word. Again, we expect Western states to meet tonight, and then that we can begin to roll out administration and education around this campaign as early as tomorrow. And I'll stop there.
Well, thank you so much, Marisela. And we have had an absolutely packed meeting. I see we are very close to time. So unfortunately, I think that we will not have time for questions, but of course, please, if you have any additional questions or comments, please share it with us in the chat, or alternatively, email Bobby, and she will make sure that we get it. And we see, I see there are a couple of comments in the chat, so we'll make sure to receive those. I want to thank everyone for making this process so rich. I want to thank our teams, Secretary Richardson, Emily, Lisa, Dr. Kushel, Emilio, Deep, Cassandra, Dr. Dominguez, Martha, Marisela, for all of this information. As we can tell, there's an incredible amount of work that's happening, and that work has been informed by your advice and expertise, and we're incredibly grateful for that. At our next meeting, which is on June 23rd, from 3 to 5 p.m., again, I want to reiterate that this will be our last meeting of the CVAC. And so we'll have an opportunity. One of the things we'd love to do between now and then is if you all could reflect on some of the learnings that came out of this process, and things for us to take away, things that you have reflected on. And if you can share that with us by email, there won't be time in the meeting to hear from every single person. But one of the things that we'd like to do is perhaps pull some of those ideas together and reflect on that in our next meeting. We'll also have a few more updates for you on equity metrics coming out at our next meeting. So we'll be pleased to share that with you. And with that, I want to offer to my co-chair, Dr. Pan, any closing thoughts or comments?
I know we're short on time, but just want to echo huge appreciation. It was quite the lineup today. Just some amazing lessons learned, some great feedback in the chat, and it continues to be such a valuable opportunity to work with all of you. And again, really, this is where it really helps to have all of your input on meeting people where they are and that ground game we've been talking about. So thanks to all of you so much. Thanks for all the work on the team for putting this whole meeting together too as well. Thank you.
Thank you, everyone. Have a great evening. We'll see you in June.
Thanks so much.
Thank you, everyone. See you soon.
Thank you. Bye-bye.
Thank you. Bye-bye.
Yeah.